Public. And
Order, good morning. This is the Health and Social Care Select Committee. We're back for a second day in a row, Tuesday 21st of May. We're in Committee Room 16 in the House of Commons today. This is the second oral evidence session of our big inquiry into NHS leadership, performance and patient safety. That's our focus, that and productivity in the NHS. Today we're particularly focusing on patient safety. This session is going to have a look at how good leadership differs at different levels of the NHS. We're going to be looking at leadership standards over the NHS in recent years and the effectiveness of mechanisms for speaking up in the NHS. Clearly, it could not be more topical. So we have two panels today, and we're going to finish at 11:30 them both. So panel one in front of us now is Dr. Jayne Chidgey-Clark, who's National Guardian for Freedom to Speak Up at the National Guardian's Office, and Miles Sibley, who is the founder of the Patient Experience Library. Thank you both for coming. I suppose we should start where yesterday left off. You will see, obviously, what was said yesterday, and there will be more that is said today in this place. The East Kent report by Bill Kirkup, which I'm sure you know, started with an open letter saying that everything he was saying he had said 7 years earlier in the Morecambe Bay investigation. This to me seems to be the nub of the issue. And we heard a little bit yesterday, lessons learned. We will hear it today, constantly. Why don't we seem to be learning lessons? Shall we start with you, Jayne?
Good morning, and thank you very much, Chair, for the kind invite to present a panel today. It's a real privilege. It's such an important topic that you're considering. Why is it that we're failing to learn the lessons? I think it's very complex. I think one of the clear things that is broken is culture, and culture takes a long time to change. Report after report has shown that we need cultural change. It's not the processes, the procedures, the policies, they're an important underpinning. It's the cultural change to put patients at the very heart of what we do, over and above performance and finance. Those are very important, but if we don't put patient safety and patients at the very heart of what we do, and therefore the same amount of effort that we put into performance and finance, then I think that's why we're failing to learn the lessons. But it's very complex, and I could talk a lot longer, but I'll start there.
Okay. Miles, tell, for the benefit of people watching, the Patient Experience Library, just in a sentence, what is your raison d'etre, and then give us your reflections on yesterday in the context of the question I've just asked.
yeah. Patient Experience Library is an online research database gathering written studies and reports on people's experiences and involvement in healthcare. We set that up because we noticed that an NHS which says that it wants to be both patient-centred and evidence-based didn't have a coherent, all-in-one-place evidence base for patient experience, so we built the library to fill the gap. It's open access and free to use. I think this question about why aren't we learning the lessons? Why do we keep seeing the same things happening over and over and over again, from Midstaffs through Morecambe Bay, on through Shrewsbury and Telford, East Kent, and infected blood and medicines and medical devices and all the rest? I point to two or three things. Firstly, I think this, and Kirkup himself actually in the East Kent report, pointed to the multiplicity of inquiries, each one of which comes out with dozens, often hundreds of recommendations. And I think this leads to a confusion, and there's research which describes NHS managers faced with all of these reports and inquiries having to contend with priority thickets. They get lost in hundreds and hundreds of recommendations, and Kirkup himself said there's too many of these, there's too many overlapping and sometimes conflicting reports and recommendations. It's hard for people to make sense of that and know what to do with it. That's one part of it. The other part of it is, if we're talking about learning from lessons, one of the key lessons is listen to patients and families when they're speaking up, and staff as well, of course, because in every single one of these instances, people have been speaking up, sometimes for years, as we've seen with infected blood, before they're finally believed. The people charged with hearing patient voice and learning from what people are saying I'm talking about the PALS teams, the complaints managers, the people in all the 150 health watchers across England, and so on. They are almost unique in the NHS workforce in having no professional qualification. So clinicians can't practice without a qualification, finance managers in the NHS are qualified, HR people, the caterers have qualifications, but patient experience, people who are listening to the patient voice, aren't qualified. There's no professional development for them. And on top of that, they have no analytics to help them make sense of all the data they're faced with. The data comes out of Friends and Family Test. March 2024, across England, there were nearly 2 million comments came through Friends and Family Test in 1 month alone. Also, the national patient surveys, thousands of health watch reports being published every year, and people doing patient voice work have no analytics to help them make sense of this data and understand what it's telling them. And we often hear in some of these inquiries about complaints handlers, for example, simply processing complaints, trying to resolve them within time deadlines rather than actually learning from them. So I think there's a failure within the patient voice piece of the NHS workforce to be properly supported, properly trained. Parliamentary and Health Service Ombudsman, in a report a few years ago called Making Complaints Count, pointed to the fact that complaints managers are poorly supported and often lack the kind of training they need to make sense of complex issues.
You seem to be suggesting that people are trying to process, get stuff off their desk, move on.
Move on, exactly so. That's happening at the front line of patient voice, people with no professional qualifications trying to do that work, trying to meet their processing deadlines, and at the more strategic end, NHS managers are faced with inquiry after inquiry after inquiry, year after year, with hundreds of recommendations. They just get lost in.
That is consistent then with what Matthew Taylor, Chief Executive of the NHS Confederation, said to us. In a way, it's not so much nothing's happening, it's when this is all added together, it doesn't seem to shift the dial. And I guess that would be that's the patient experience, is there's all these well-meaning bodies, some of which have got lots of professional qualifications, some of which haven't. Everybody's well-meaning. Well, not everybody, if you read yesterday's report. And I suspect that there are things coming for them. But there's an awful lot happening, but nothing's really changing.
It does seem that way. And in fact, back to Jayne, National Guardian last year produced a report on staff experiences of speaking up, and it was called Fear and Futility, a sense that people are afraid to speak up, but also a sense that if they do, nothing will change. That was talking about staff experience, but exactly the same is true for patients. And you can go back to 2013 in the wake of mid-staffs, and Anne Clwyd, MP, produced a report called Putting Patients Back in the Picture. And she talked about exactly the same thing for patients, a sense of fear about speaking up, but also futility. What difference is any of this going to make? So I think there's a huge perceptual problem.
Jayne, it was your report. You agree with your own report, but let's just explore the futility point briefly. So that means that people don't believe anymore, that there's a deep cynicism that anything will change, even if they speak up, even if they're right, even if they're believed, even if the sort of analysis we saw yesterday, presented as it was by Sir Brian Langstaff, even then they don't think things will change.
There is a significant number of people, the NHS staff survey shows that year on year, that do not believe that their organisation will respond to the matters that they raise, really worrying both patient safety and wider issues that they're speaking up about. Yes, there is so much more to do. What I find when I visit organisations, and there's obviously a continuum, I mean, Matthew Taylor talked about that, the continuum of organisations that are performing better to those that aren't. And what I find in those organisations that are performing better when it comes to their culture, their speaking up culture, and often that's related to better ratings, better patient experience and outcomes, is that they have a sense of absolute curiosity about what the data and what the stories that people are telling them. That's both staff, but it's also obviously the patients. when you go to organisations where they're struggling much more, very often the focus is on other things. It is on that performance target or that finance target, and the culture isn't given the same weight. I can go to board sessions and I can look at board papers. You can get a sense, is culture last on the agenda, often, after committee's finished, and it's like, for noting. Any questions? Move on. That gives you a huge sense about the priority an organisation is putting on its culture. And all the while that the centre is measuring performance and finance, which obviously is key, but there's the third part of that, and that's the cultural metrics. That's how are we listening? How are we listening to change? How are we taking these recommendations? And I agree with Miles' statement that there are so many recommendations, and there's currently work, my office is involved with other patient safety leaders that you've heard from in written evidence, working on streamlining that recommendations, making them more evidence-based and more manageable for organisations. Having been a non-exec director, I'm a nurse by background, but having been a non-exec director in an NHS organisation as well, I know what it is like for boards faced with plethora of recommendations out of all these reports, plus all the compliance issues, and it can be too tempting to focus on just ticking the box that we've done that, we've dealt with it, but not really getting under the hood of has behaviour changed at the front line, because that's what needs to change. So a curious board.
But that's what the former Prime Minister Theresa May said yesterday in the House, is that in her opinion, too many people are watching their own backs and not doing their jobs on behalf of the public. I mean, we are all constituency MPs around this table. We get casework. If we just tick the box and then put that casework on the done pile, the constituent will very soon come back to us and say, well, that hasn't been done. I can't understand why public servants in the NHS or otherwise think that they are different. Anyway, have a think as we're going and as other people are talking. Have a think about where you think this is being shown to work well, where you think this kind of leadership is leading organisations at system level, trust level, DPH level, primary care network level. Have a think where you think it's working well, where you've seen good leadership. And anyway, as you do that, let's bring in Paul Blomfield.
Well, thanks, Chair. And really to pursue this theme a little further, because Jayne, you talked in your opening point about, and you've repeated it a number of times, in terms of the way in which culture of the NHS prevents progress in this area. And the staff survey not only demonstrated their sense of fear of speaking up, futility of speaking up, which we've talked about. It also showed that those numbers are getting worse slightly over the years. So we're not even incrementally moving forwards, we're moving backwards. There's also within the survey the sense that staff who make mistakes aren't necessarily treated fairly. So many efforts to address this issue and no progress. What should we be doing? And I guess it's kind of following up on the Chair's point. Where are there examples of good practice from which we can learn?
Yeah, thank you. Really important point, and I think if I can start with some examples of good practice, if I can talk about organisations that I have engaged with. And I've been out on visits, I've seen how their leadership team, when we're walking around, how they're engaging with teams. They're known, they're visible. It's a key part of leadership, is that visibility. And, even to the point of being in a lift and someone saying, I wanted to catch you, and just, didn't know who I was. It wasn't a planned meeting. Need to talk to you about X and Y. That approachability and that, yes, here you're going to act. So it's the visibility of the whole leadership team, but it's also that it's what they showed me on the particular visit I'm thinking now, and I've seen other examples of this, is that it starts at the tone from the top, but it's absolutely embedded at the different levels through an organisation. So you go into a clinical area and the teams are talking about their safety huddles. They're talking about how every day they're getting together. They're talking about what's it feeling like today? Is there something we need to raise, to escalate? They're actually feeling not unsafe to raise matters that are going to get in the way of patient safety or, how it's going today. Then if you look at their governance structures, their governance meetings, their appraisal systems, their one-to-ones, it's on everybody's lips. What is it like here today? What are we doing? What do we need to do more of? How are we addressing that? Is there anything I need to know? That's a very curious question for a leader. What do I need to know? What do you need to tell me? What do I need to hear? So I think when we see that, we'll often see an organisation where the workforce are feeling valued. And I have a strong sense that there's a very strong correlation between those organisations that have a better speaking up culture. They've also got a better quality improvement culture, because we need people who can speak about patient safety. They're your early warning. Our workforce are absolutely vital for telling us what's going on. But they can also spot, the front line of they've got the best ideas for a better way of doing it, a safer way of doing it, a less expensive way of doing it, more effective and more efficient. If we clamp down on ideas because we don't have a culture where we value everyone's contribution, the most junior to the more senior, then we're not going to get the best out of our workforce. They're not going to feel valued, and most importantly, they're not going to tell us when there's something to really worry about. And that's, as a leader, what we need to be curious about. So there's better organisations are much better at putting it right throughout the system. It's not having a board report twice a year that comes about, data from the Freedom to Speak Up Guardian. It's so much more than that. It's layer upon layer. And we've produced a self-reflection tool that we encourage boards to reflect on where they are in their journey and have an improvement plan. When you self-reflect, it's not just about leaders sitting in a dark room deciding. Those better organisations are engaging with their staff networks, they're looking at their staff survey results, they're doing pulse surveys, they're asking in team meetings, they're using a plethora of mechanisms to understand, because the workforce know what their barriers to speaking up are, and if you give them safe spaces to talk about it, then they'll help you look at the solutions to addressing it. And indeed, we have some organisations where 75% of the workforce are feeling it's safe to speak up and that something's going to be done about it, and then we have others that are at the much lower end. So we need to learn better from the best and quicker from the best as well.
What you're describing very comprehensively and very passionately is management theory that could apply to any organisation. Car industry actually looked at the benefits of empowering the workforce more than 2 decades ago, and some manufacturers, I think Nissan led on it, transformed the way that they ran their factory. So it's pretty standard management theory, really important. Why are so many NHS leaders failing to embed it in their organisations?
I think this is a complex situation, and I think, are we recruiting leaders with the right values? All the leaders have the right values, the right skill set. Obviously, there were recommendations coming out of the Clark review, and NHS leadership are looking at that competency framework, but they haven't been embedded yet. So we can't expect people, particularly at the new leaders, but it's not just new, it's all, to necessarily have that understanding of what those requirements are and how to do it, how to have those difficult conversations. It is really hard. I've sat on boards. It's hard to be curious when you've got bad news, when you've got a challenging situation, but we see too much the defensiveness, and are we giving enough support both from the centre and as we individually develop and support our managers and leaders? Are we giving them enough support to know how to have those difficult conversations and to be brave? Because very often that external scrutiny then says, well, you're wrong, that's wrong, and so the blame culture is far too apparent. And I think we all make mistakes, and we're not born managers and leaders. We have to be appropriately developed and supported to be the best we can be. Sir Gordon Messenger talked very eloquently about that. So I think there's much more we can do up front in terms of training, development, support, to make sure we've got the best.
A thought, does anybody sit down each year when the NHS staff survey figures are published and analyse them and think, hang on a minute, that trust is getting it profoundly different, their numbers are so much better? What can we learn?
Absolutely. After last year's staff report, those that were performing most highly, those that were the most improved, and those that were the worst performing, I wrote to and I said, for those that were the best, can we come and can we learn what you're doing, what's going to make a difference? And then we can do case studies, we can share that best practice, and that's really important to have time to do that. I think I heard Matthew Taylor talk about how he was surprised that leaders don't spend much time going to other organisations and finding out, and we need more of that. But I think we can't underestimate the huge pressures that our current NHS organisations are under, both in terms of capacity and performance and finance. But we need to allow people the time to do that and make it an expectation rather than it's a nice to have if you can find the time. Because otherwise, how do we learn from the best?
Thank you. That's brilliant. Thank you, Paul. Shall we bring in Paulette Houghton now?
Good morning. My questions are for you, Dr. Clark. I've really enjoyed reading about these guardians that you're trying, not you personally, but the NHS is trying to put in place. Now, these people going in are supposed to be independent, they're supposed to be allowed to really grow and develop within an organisation. The problem that I have with what I've read is all organisations are required to have them, but the implementation of the role varies greatly dependent on where you are, and it's quite inconsistent, and it doesn't meet with national guideline standards. Can you explain why this is happening, why we're not able to recruit? Thank you.
Yeah, thank you very much, and really important area, and obviously one that's very close to my heart. When the Freedom Speak Up Guardian office was set up, and this role was set up in response to Sir Robert Francis's Speak Up review and the earlier reviews into mid-staffs, very much the vision for the role was to be that additional safety route. So if people can't speak up to their line manager or other routes within an organisation, they would be able to go to this independent and trusted person, and this person would manage their cases, would make sure they got to get addressed, and would also act as an ambassador for cultural change within the organisation. So when the role was envisaged back in 2017, I've been in role since December 21, when the role was envisaged, as with many new roles in the NHS, there was a mandate through the NHS contract that you should have this role, and here is a universal job description for you to use. But there was also freedom to adapt, with a recognition that different organisations would be at different points in their journey, the trust of their staff, need for the Guardian. So there was some leeway in implementation. Having said that, there was guidance about the role should have protected time. You don't give somebody a role on top of a really busy day job, because how are they going to have time to do that? And guidance around where it should report into the organisation. We have guidance that it's not suggested that it should be a exec or a non-exec leader in the organisation because of the hierarchy, and we know that hierarchy can be a really big barrier to speaking up. What we suggest is that the role is sitting within the organisation, has direct access to the chief executive chair. So we have a number of a sort of a framework for how we see the role, but then it is down to individual organisations to decide how they want to implement that role based on best practice. What we see is an absolute inconsistency, which is a big disappointment to me. We carried out a review of the 10 ambulance trusts in our Speak Up review that was published last year. Within that, we saw far too many examples of trusts having minimal Guardian sort of hours, dedicated time to carry out the role, many big cultural issues, and that's replicated when we look and we do our annual survey of Guardians to see the sort of way that their jobs are managed. We have some organisations that might have 2 full-time Guardians and other organisations that has a very part-time Guardian. And that inconsistency is a worry. Our office wasn't set up to be a regulator, so we can't absolutely dictate. However, we have best practice, and what I rely on is NHS England and CQC as the regulators to help enforce, and indeed, recommendations now coming out of the new well-led domain of CQC will say to an organisation if they haven't, and they will make observations, and that will affect potentially their rating, whether they have a guardian, whether they have enough time. So the inconsistency is a worry, and it's a big worry, and I would like to see more consistency going forward and more support from the regulators to do that, and I'm working with them on that.
So just to follow on from that, I agree with you, the inconsistencies is very worrying, to say the least, because you really do need these people out there doing what they need to do. So my second question in that area: do you believe when we get the guardians in place, because it's so inconsistent, because the role, although very clear, is not being carried through, and there doesn't seem to be, there's national guidelines, but it doesn't seem to be a mandatory thing that an organisation has to do. Do you think these people are getting enough support? Is there enough resources within the role to enable them to do it, to do that role properly, to be honest?
It's varied is the answer to that, and in those better organisations it's very well resourced, and it is a role that is held in an appropriate place within the organisation with that direct. So the guardians that I speak to that feel really well supported, they have direct access to the chair, the chief exec, can go anywhere in the organisation, they have the time, they have the resource. Very often they might have a network of guardian champions to help with the work they're doing, both that proactive and reactive. In other organisations there absolutely isn't that support, and I very worryingly have heard of accounts from some guardians where they feel that when they're delivering messages around themes that are hard for organisations to hear, that some feel they suffer detriment themselves, which is clearly unacceptable.
So my final point, and we have to round up quite quickly, is if you were to give us a recommendation, because I believe if you're going to improve leadership, if you're going to improve standards, you've got these people there that you really do need to ensure you're implementing across the NHS. If there was something that you'd like to see as a fellow nurse, what would that be to ensure that that role is in place doing what it's meant to do?
Thank you. What I would like to see is consistent implementation according to the guidance. What I would like to see in relation to that as well is guardians having the protection, maybe a bit like internal audit often does in organisations, of being appointed and being stood down from their roles by the board rather than by individual line manager, to give that scrutiny, and absolutely the protected time to carry out the role, the access to the chief exec and the non-exec, to have a non-exec and exec director lead for wider speak-up culture, which is obviously much more than just the guardian route.
Excellent. Thank you, and thank you, Chair.
That's really good. Right, Rachel Maskell and then Caroline.
Thank you. Miles, if I can turn to you. Obviously, holding the system to account is part of this process, and we've talked about different mechanisms which are or aren't working accordingly. Are we measuring the wrong outcomes when we're looking at that? And if, with regards to patient safety and what is happening in the clinical environment, and if we are, what should we be looking at? What should we be measuring in order to ensure that we're getting positive outcomes and a responsiveness from the system, as opposed to a defensive culture, which clearly we often see?
Yeah. Okay. So a couple of points there. One is about outcome measurements and one is about culture, and I'll take each in turn. Yes, I think to some extent we are measuring the wrong outcomes. If you look at the kind of fixed mechanisms for understanding patient experience and hearing the patient voice, you've got friends and family test, you've got a whole series of national patient surveys, maternity, adult inpatients, accident and emergency, and so on. And then you've got the complaint system. Those are the kind of main mechanisms, and they all have their own kind of measures and all the rest of it. Now, the interesting thing about the Friends and Family Test and the National Patient Surveys is, for a start, they're not particularly patient-centred. They're more provider-centred. It's providers saying to patients, tell us how we're doing. Tell us about our services, tell us about things like waiting times and cleanliness and all the rest of it. Now, it's all good and important stuff, but it doesn't allow patients to say what matters to them. They're channeled through, in the case of the patient surveys, fixed questionnaires where the questions have already been determined for them. On top of that, you've got the fact that with the national patient surveys, the findings from them, the results, are fed back to providers typically 6 months or more after the initial field work has started. So they're always retrospective. In a sense, they're always out of date. So yes, I think and then with the complaints data, there was a piece of research that was done. It was a paper in the Journal of the Royal Society of Medicine in 2022. And what that said was that it talked to complaints handlers about how they were reporting their complaints data. They used something called the KO41A. I don't know why it's called that, but that's the name of the official complaints data reporting. And complaints managers, some of them felt that it was actually quite an inappropriate way of collecting and reporting data. One of them even went so far as to describe it as supplying false information, because of the way that complaints, which can be quite complex and wide-ranging, have to be categorized within fixed categories. So how good is that for learning? Well, some of the complaints handlers thought it wasn't. So yes, to some extent the outcome measures are not necessarily completely wrong, but they're not perhaps as wide-ranging and comprehensive and as flexible as perhaps they need to be. The second question was one about this question about culture and so on. Now, I think our understanding of culture in the NHS, organisational and professional cultures, is often not very good. And when you look at all the inquiry reports over the years from mid-staffs onwards, they very often talk about problems with the culture of organisations. But they often talk about culture as a singular thing, and they often don't really say what culture actually is. Now, we've all heard the saying that culture is just the way we do things around here. But that's a hopelessly vague way of describing it. It doesn't help people understand what it is. We did a piece of work for the CQC about a year ago now, where we went back through 10 years of official inquiry reports, 19 separate reports we looked at, and we didn't look at the recommendations coming out of those reports. What we looked at was the detail of the evidence that had been uncovered by those inquiries in respect of professional and organisational cultures and how those go wrong. And the hook for this was Bill Kirkup's report on East Kent, which was called Reading the Signals. And there's something really important there about not necessarily waiting for inquiry recommendations, not necessarily looking at outcome measures, but learning day to day in your practice and in your management of the service to read the signals as things start to go wrong. We did a big thematic analysis across 10 years of avoidable harm inquiry reports looking specifically at culture, and we identified 6 different types of culture. So those are reporting culture, compliance culture, caring culture, teamwork culture, accountability culture, and learning culture. And we pulled out masses of reference to these, looking at what is known to have gone wrong with these sorts of things. So, and also looking at the different states in which those cultures can exist, those being complacency, avoidance, and denial. And from that we built a framework which we've given to the CQC, which can help people to get a much better, much more forensic understanding of what types of cultures exist, professional organisational cultures in healthcare, and how they can move between these different states of complacency, avoidance, and denial, with examples taken from these inquiry reports. You referred to the thing about management theory, but what we were looking at here was not theory, but what is known to have actually happened time and again in these different places. And what you see is what Bill Kirkup refers to as patterns of behaviour. You can start to see the way in which for example, at Gosport, complacency there was characterised by case notes not being filled out sometimes for entire days, and management seemed to be okay with that, and ward managers and so on. With avoidance, you can see things like in the case of Ian Patterson, the breast surgeon, who's now in jail, whose colleagues described him as a unique rogue. They knew he was up to something, but they didn't really want to have to tackle it. And then when you get into denial, that's when you see examples of things like case notes being lost, and active cover-up, and as at Morecambe Bay, midwives colluding over the accounts of care they would give to investigators. So it is absolutely possible to get beyond this wishy-washy notion of culture as the way we do things around here, to get to a much more forensic understanding. And for me personally, I think if we can put that in the hands of health service managers and health professionals and ward staff and so on, and of course the people dealing with patient and staff voice, who are also sometimes not quite sure to do with vague worries that something's not quite right, I think we can actually give people a much better tools then to tackle these things, to do what Bill Kirkup describes as reading the signals, and get there before you end up in the inquiry and the recommendations and all of that.
Jayne, if I can bring you in, and I just want to ask you, in addition, just to reflect about, obviously we have a litigation culture as well, which is driving much of this, the protectionism of organisations, but also huge inequality of power, whether it's a member of staff or whether it is a patient or a carer within the system, and how we equalise to enable a co-production of outcome, as opposed to what we've got at the moment is a very authoritarian approach to complaint handling.
Yeah, thank you. That power differential is absolutely huge, and we see it played out far too often in those high-profile cases. I think taking another C from your culture is the culture of curiosity. Those best organisations, coming back to Chair's comments about where do we see the best, those organisations that have a culture of curiosity and therefore are listening and looking and examining deeply their data, and that's data coming through all sorts of routes. That's the patient experience data, that's the patient outcome data, patient safety data, safeguarding data, HR, bullying, harassment, alongside the data coming through freedom to speak up. If you have that culture of curiosity where we want to see it and we want to know, the good, the bad and the ugly, because then we can address it, and that culture of complacency, or that culture of, I don't want to know because it's almost in the too difficult pile, I want to hear what's good. There are organisations that we talk to that are not afraid of having the uncomfortable conversations, and there are others that we call comfort seeking. Oh, we don't have many numbers of freedom to speak up cases, that's a good thing. Well, there's no precise of what's a good number. Well, we don't have that many data because we don't have many patient safety reports. I worked in an organisation once where that was, as a nurse, I was told, it's really good, we don't have many patient safety reports here, and I was thinking, we're not reporting near misses, and we make mistakes, but if we have a blame culture and not a culture of curiosity, we're not going to have that. So I think that power differential very much is really important to bear in mind. And again, those best organisations are co-creating. They're doing it through the work I described earlier, through the multiple levels of engaging with workforce to understand what it is that's going to make it different. Clearly, there is always going to be hierarchy and power, but when we move away from the defensive culture to a more open culture, admitting our mistakes. And, we've been talking for a number of years in the NHS about a just and learning culture, but we don't always see good evidence of it. We very often see it's blame of it. We look for blame of an individual rather than a no blame, as we see in other safety industries, where as long as it wasn't a deliberate error, an error, a human error, is not blamed. It's what can we learn from it, and we'll take that gift of learning.
All right, thanks. And then very briefly, Caroline Johnson, then we're going to move on, if that's okay, because we're just to the tech ops, just get the people lined up for the next session.
Thank you. I've got two questions, really. Why do you think inquiries take so very long and so long compared with international comparators?
Yeah, it's a very good question.
And what is it that we're doing that takes so long? And that gives people an opportunity to say, that was ages ago, things have changed since then, and therefore not to really look more closely than that. What can we do to make these things quicker and more efficient? Want to take that one first, or shall I? I'm very happy to. Do you want me to?
So I think that's probably an area out of my remit. Just as looking at, I think sometimes the decision to carry out an inquiry will take too long. Sometimes we have quick decisions to have an inquiry. I think the defensive culture can get in the way of people giving the evidence in a meaningful time. But I think sometimes it is just human business. We know this extreme pressure that the NHS is under, if we're talking about NHS inquiries, and therefore that can impede. But they do take far too long, and it is, we look back over the blood scandal, and I was reading Sir Brian Flagstaff's report last night with deep dismay, and there will be a potential to say, oh, but that was back then. But actually, for the messages to the health service now around leadership and accountability, that message is for today, because we're seeing it time and time again. So I think we need to have timely investigations by expert investigators who are trained in investigations. Far too often investigations are done by people who's an add-on to their day job and haven't had the necessary training. So that sort of safety for science of investigation and timely call for those inquiries, timely investigations, and very much going back to your phrase, Mrs. Maskell, of co-creation, And I think if as a workforce within the NHS, we understand the importance of learning, then and we see the actions coming through quicker, that will certainly help.
Thank you. And do you have anything to say on that, particularly in terms of sometimes we listen to every single story, and there are reasons why we would want to listen to every single story rather than a representative number of them, but it does make things take longer and lessons take longer to learn. What would be the sort of patient experience view of that?
I think the point about listening to every single story is actually necessary because people are hurt, harmed terribly. If you look at things like pelvic mesh, life-changing injuries, if you look at deaths in maternity, people losing their babies, and then encountering the further harms of cover-up and denial and all of that. And I think people need to get their... The NHS is a healing organisation. Being heard is part of healing after harm. So I think people need to have ways to be heard. In terms of delays, I can't talk for inquiry processes, but in terms of the time it takes for these things to come to inquiries, I think partly it's because of these cultures of avoidance and complacency and avoidance and denial and cover-up. Foot dragging is a tactic. And when you read inquiry reports, you see examples of this all the way through. Again, things like case notes being mysteriously lost. It's a tactic. And you can go right to the start of this, where people start to raise concerns and find they're hitting a brick wall almost straight away. There's a term that is commonly used across healthcare when talking about patient voice and patient experience, and that is a term anecdotal evidence. Now, when people talk about patient stories being anecdotal evidence, that's a kind of a shorthand for saying they're subjective, emotional, irrational, unreliable, and basically shouldn't be given too much credence. And it starts there. The term anecdotal evidence is not just dismissive, it's contemptuous of people's experience. And I personally would like to see it never mentioned again in healthcare. It starts there, and that's where the delays come through. There's research that has been done. Health Watch England some years ago did a report called Suffering in Silence, and it's been confirmed by other studies since, about muddled routes for finding your way through complaint systems. Is it PALS? Is it complaints? Is it Health Watch? Where do I go? So people having to navigate their way through, meeting these dismissive attitudes on the way, and then when it all starts to get really serious, encountering denial and obstruction. And this happens to regulators as well. When the CQC went into East Kent, this is revealed in Kirkup's report on East Kent, they were met with an aggressively hostile response. CQC investigators forced to sit in a corridor and wait for 45 minutes after the supposed start time of their meeting as a tactic. So I think inquiries themselves, as I say, I don't know about the processes and the complexities of that. But what we do see time and again is patients and harmed families having to speak up sometimes for years before finally being heard. And I've just finished with a quote from Baroness Cumberledge, Medicines and Medical Devices Safety Review, all the terrible harms from Primodos, sodium valproate and pelvic mesh. And she said, patient experience must no longer be considered anecdotal and weighted least in the hierarchy of evidence-based medicine. Yeah. That's something that the whole of the NHS needs to hear and act on.
Thank you. That's very interesting. My other question was about the culture. And we often hear about comparisons with industry, particularly the aviation industry and other travel industries. But does recruiting NHS managers from within the organisations of the NHS not perpetuate the same culture? We don't see, you see people who go and work for one business and then another business in a different field, and they move around the private sector. But NHS managers tend to be more recruited from within. Many of them have previously been clinicians. Does that not perpetuate culture? What could we do to get in managers from other cultures?
I think if it's a really interesting point, because it's about having a diversity of talent. And indeed, Sir Gordon Messenger talked about the talent pipeline and how we nurture our leaders. I think there needs to be a mix, but recruiting just because someone has come from a different industry probably is because you need people with experience. I think what I'm trying to say is you need a mix of managers and leaders.
We don't have that, do we, particularly in the more middle and junior ranks? I mean, if I think of the managers that I've worked with, they've mostly been people who used to be the senior nurses on the wards that I've worked on. They're now supervising the same. So you've got a continuum. If they're good, that's great. But if it's a poor culture, you've got a continuation of the same culture within the management structure because it's the same people.
Yes, and I would say that's the same across any sector. But often you want specialists who understand the business within which they're working. It comes back, I would suggest, to the the management training, the leadership and management training that we're giving. We quite often will promote, take nursing for an example, into a leadership position with very little preparation for that. There's an expectation just because you're more senior that makes you a good manager, and of course we know that's not true. If you have a great learning experience and you've got great role models throughout your organisation, you will then develop those cultures. But if you have poor, so there's something about how we are training and supporting our managers. And I did want to ask, Chair, if I could offer to share some further information around training and support, and particularly on the item that...
well, that would be great. It's not uncommon for witnesses to write further to evidence, so that would be great, yeah.
Do you think when you're appointing managers, you've got that balance between having someone who's great at management but doesn't have clinical experience of the area they're working in, or even clinical experience at all? And then you've got other people who may apply with lots of clinical experience and knowledge and skills in the area they would be working in, but not necessarily, as you say, the management training experience. If you're appointing a manager, is it more important they've got the clinical experience, or more important they've got the managerial skills?
I would say it depends upon the role that you're appointing them to and what you need and that skill set. And I think there are some clinicians who are excellent managers, and there are some managers who don't come from a clinical background who are excellent managers. I think we need a better focus on how we prepare and support our managers from whatever background they come from. Yeah, thank you.
Okay, right, we're going to suspend briefly because we get some virtual witnesses up. So thank you very much to Miles Sibley and Dr. Chidgey-Clark for giving us your evidence. Thank you. Order. I'll just quickly change round. Yeah, we're still okay. No, we're okay. You can hear bagpipes, can't you? I'm not imagining that.
It's on the bridge.
I know it's on the bridge, but I didn't.
They're all summer, isn't it?
At least I can hear it in here with the windows. Oh no, they're not quite close. thought I was imagining things. I was imagining hearing bagpipes. This is a new innovation for me. Hello, Kamila.
Hello, nice to see you.
Good-o. Right, ready?
Can we ask if Sam...
Hello, Sam. Hello, Linda first. We can see you, Linda. Good, you can hear us. If you unmute yourself, unless you're in a train station, which you're clearly not, then you can just keep it unmuted. And Sam, we can't see you.
I can hear you. Hopefully you can hear me. I'm trying to
That's fine.
address
We'll get started, and you can go out and in if you need to, but as long as we can hear you, that's the most important thing. And it says along the bottom who you are, so there's no question as to who's who. Right, ready? We done?
We're done.
Okay, right, order, we're back. This is the second panel of our latest part of our inquiry into NHS leadership. We have in the room here Professor Kamila Hawthorne, who is well known to viewers, I'm sure, as Chair of the Royal College of General Practitioners. We've got Sam Allen, Chief Executive of the North East and North Cumbria Integrated Care Board, who we can hear but can't currently see, but that will correct itself, I have no doubt. And we have Dame Linda Pollard, who is the Chair of the Leeds Teaching Hospitals NHS Trust. Excellent. Right, James Morris is going to kick us off.
Thank you, Chair. I just wanted to kick off. I mean, obviously there are a lot of management and cultural challenges within the NHS. Just starting with you, Professor Hawthorne, do you think that the performance management regime and emphasis of top-down targets and that culture is partly to blame for negative culture within the NHS?
Feels slightly like a leading question to me, but certainly in general practice, we are very, very much affected by targets, and particularly access targets, as I'm sure everybody in the room will know. And of course, when you've got a finite working capacity, then the more pressure you put on targets, the less availability you've got for continuity of care, which of course affects patient safety. So if we're talking about prevention of incidents, I think that there is definitely a real pressure there, which we see in secondary care as well from our primary care vantage, but it's definitely happening to us in primary care. And we know that from our surveys, our tracking surveys, that about 46% of members who've responded to our surveys have said that they don't feel they have enough time to adequately, safely manage patients in their consultations because of the pressure.
Sam Allen, as a chief executive in the North East, in North Cumbria, what's your reflection on the pressure that's placed by performance management expectation in the NHS and that on your ability to manage other issues and to develop a culture of curiosity and learning, like very much we've been exploring in our first session this morning?
Thank you very much, and many apologies, my video doesn't seem to be coming up. Okay. So I think in terms of performance, we'd certainly expect there to be pressure on performance. We are a national health service and the public expects and requires standards to be met wherever you're working from in the NHS. In terms of a learning culture, though, it's certainly been a priority for us in the North East and North Cumbria to set up what we've called our learning and improvement system, which has been very focused on learning as our engine for improvement. And in terms of learning from others, really trying to foster a culture whereby we're curious, we never have the attitude that it could not happen here. We are openly learning from others, not just across the NHS, but globally as well. And through our learning and improvement community, we have connected up with other organisations globally because we want to learn from the best. But the cultural side is the real focus. It has to be, we are a people-based organisation. And if we're thinking about management and leadership, culture is created by the people that work in the organisation. So this needs to be purposeful. We need to really focus on learning and improvement with real intent. So it's not an either or, it's an and. And of course, if you're focusing on improvement, performance is at the heart of it.
Yeah, just as a follow-up question, what I'm trying to get at is over time, the NHS as an organisation has become, it's an organisation that's very good at examining the problem. We spend sessions like this, there's examining the problem, but the solutions are difficult to find. And what I'm trying to get at is the hierarchical nature of the NHS system, where managers are expected to comply with performance management, they're constantly looking upwards. Does that have it kind of has a negative managerial effect, if you like?
Well, I mean, if you're always looking in the rearview mirror, you'd certainly have less time to think about the future and look forward. And I think if, as a manager in the NHS, and I'm a manager myself, I would say that sometimes we have a propensity to focus on the planning. And in fact, I think if we focus far more on the delivery of things, then perhaps we would be seeing some different results. But part of that, of course, is the very context and environment within which we work. It's highly political. We're on short-term planning cycles. It's difficult to plan for the long term, and particularly with security around the resources that you've got available. So the environmental context within which we operate is wholly important in the context of the NHS. So again, it's not as simple as saying, if we spent more time just focused on the delivery, then we would get those results. We've really got to think about the context within which we're asking NHS to managers to operate within.
Okay. And Dame Linda Pollard, reflections on that, the tension that exists within the system, which can have quite negative, maybe unintended, but negative consequences. What's your perspective?
Yes. I am chair of Leeds Teaching Hospitals, and I'll try and wear that hat and the messenger review, because of course I'm co-author with that, and Gordon stepped back, and I'm still heavily involved in it. That's just for information for the inquiry. I agree with Sam, absolutely. I think it does revert back into what we found during our 6 months, and probably about 3,000 people that we talked to, Gordon and myself and the team, about exactly what you've hit upon here. How do we stop looking in the rearview mirror, as Sam's said, and internally focus? So, as chair of several health organisations over my career, and by the way, I'm very private sector and don't come from the NHS, I'm not a medic. I think it has to go back to, and it's an easy word to say, the culture, but it is how you then engage, communicate, the visible, the transparency that organisations have. I mean, it's 22,000 people here at Leeds in my trust over 7 sites, so it's quite hard to touch. And just reverting into that, away from the national picture, we were in a dire strait 12 years ago with a massive deficit, with probably one of the worst staff services I've seen in any sector that I've worked at. And now, and I'm not blowing my own trumpet, and I hope Sam would agree with this, we are probably one of the certainly top 3 in the country now, and we are very, very big and very, very complex. But you have to stop looking in the rearview mirror, because it is a cultural thing that you develop. The Toyota method, that it's a management tool. I was trained in it in BMW many, many years ago. We've got that here at Leeds. We've been working on it for a long time. We need that right through the system to stop looking in the rearview mirror, that people will trust you to engage, get the stuff in the right place. At the end of the day, this is about, patient delivery and getting the right service in the right place at the right time. Do we share? We're dreadful at it. Mostly because, as Sam's very eloquently said, there is too much looking in the rearview mirror and not enough. Will you just leave us alone? You've got to trust us to get on with this. But it does lead me very, very much back to the recommendations within the messenger review, that unfortunately not everybody is in the position that, say, for instance, Leeds is at the moment. There is a handful of us, absolutely, at delivery level. And whether we're talking about mental health community, or providers or even ambulance services.
Okay, so thanks.
Social care is missing there as well.
Yeah, no, thanks for that. I think, Chair, there's much more I could explore, but I think we probably should.
There's always more,
Indeed.
Mr. Morris. That is the nature of our lives. But thank you very much for that. I'm going to bring in Paul Bristow now.
Thank you very much, Chair. Professor Hawthorne, are GPs always the right people to manage GP surgeries, if you like? I mean, quite often these can become big centres serving 30,000, 40,000 people in the case of Peterborough. Do they always have the right skill set? Are they always the right people to manage these mini hospitals, in effect?
So, in fact, there are even bigger federations of GPs that have 100,000 patients in them. And very often, most practices have a practice manager who is employed by the GPs to manage the practice. In terms of the actual direction of the practice, the strategic direction of practice, I suppose the leadership, which is different, of course, that's usually done by the GP partners who, of course, own the business. And it seems to be only right that they should do so. Now, you're going to ask me, well, what training do they have in leadership and management? Many medical schools nowadays are including a vertical theme in leadership and management, which is generic. And then during the GP training scheme, which is a 3-year-long scheme, there are opportunities to learn leadership and management, but not enough, not nearly enough. It's a very condensed programme. And many GPs need much more training, which is available, but it's about having the opportunities to get that training.
What I see in my experience as a constituency MP is enormous variety. I see GPs who are natural entrepreneurs, who are running centres and running these bigger practices very effectively. But then I also see people who are probably brilliant GPs, but don't have the skill sets in order to employ staff, manage systems, think of processes that would enable patients better flu through. It's a complicated thing. Brilliant GPs, brilliant medical professionals, but this wasn't really what they signed up to do.
It isn't what they were trained to do. We're not trained to be experts in managing HR processes, for example, and many of us have learnt on the jobs. I certainly have. Nowadays, though, it is possible to have that training, which is why we're very keen as a college to push the new to practice fellowships that are currently being closed down by NHS England across England. So these are fellowships that allow newly qualified GPs to spend 2 years in a salaried position in one place where they can actually really get stuck in, learn how practices work, learn how practices should be led and managed, how the finances work, how the HR works, and have some time to develop themselves professionally before they then go on into other practices. And many of those, from the evidence we've got in terms of how effective they are, show us that these GPs are then taking on PCN and higher leadership roles, because one of the problems we have in the NHS is that there aren't enough GPs in leadership positions in the NHS executive and in the higher levels of the NHS.
Do we have the right model in general practice in your mind? Because in effect they are mini businesses, aren't they? But they have it's not like they can go bust, in the sense that, they can go bust, but it's not like there's always going to be a demand for their services. So in that regard, do we have the right model when effectively we can be, I suppose, allowing patients to be seen by people who are just not up to the job a lot of the time? In terms of managing the practice, not as a GP, in terms of running the practice.
I think perhaps you ought to retract some of that. They are up to the job. They're working well as GPs. We are finding that some practices are going to the wall, and they're going to the wall because financially they're not able to cope, and they haven't got enough GPs to actually run the practice properly. I don't really accept what you're saying that some GP practices aren't worth the money that they're receiving to do the job properly. They are doing the job properly, and we have really quite stringent regulation to pick up those practices, and there will be a few that are not.
Yeah, well, I'm not going to retract what I said, because I think it's a very fair comment to say that if you've got hundreds of thousands, tens of thousands of GPs practices across the country, some are not going to be fit for purpose. And I think a lot of that can't just be blamed on money. I think
there will be a few, but from CQC's regulation, that number is actually very small. It's less than 5%.
5% is still a significant number. Can I go to perhaps Sam Allen? So I just want to talk a little bit about patient representation within leadership and patient feedback to leaders in our NHS. Do you think patient feedback? Do you think the patient voice is being heard by leaders in the NHS appropriately?
I think we've got many mechanisms by which the patient voice is there. So, for example, on the Integrated Care Board, we have Health Watch as a member, we have our community and voluntary sector organisations represented, and we also have a patient voice committee within the Integrated Care Board where we're seeking to always triangulate views. So I think we've got some good examples of that, and we've also got some really good examples across the NHS of patients as leaders, so patients in formal paid leadership positions as well. I think, though, just in terms of the focus of your inquiry, there's equally ample evidence where it hasn't been heard. And in terms of from a management and leadership perspective, having an approach which is very centred on the patients and deploys different approaches in order to be able to hear what people are saying and getting alongside people, I think is something which is subject to ongoing improvement, and particularly working with representative patient groups. But for us in the Integrated Care Board, really working through and with our local authority partners through their democratic links in terms of hearing the voices of our communities being absolutely fundamental. So I think we've got some good evidence of some good models, but there's certainly more that we need to do. And I think particularly when it comes to safety and listening in order to take preventative steps and actions in order to reduce risk and keep our patients safe.
And do you feel that Health Watch is an effective organisation in ensuring that the myriad of patient experience and patient views are heard? And is it the case that there are appropriate systems and structures in place to enable Health Watch to be heard?
Well, I can speak from our experience in the North East North Cumbria. We have 12 Health Watch organisations. We fund and work with them in a way which enables them to be representative across the Integrated Care Board. And my view is I think they do very well with the resources that they have available. They are in touch with the key issues that our communities are raising, the sorts of things you'll be very familiar with, such as dentistry access, for example. However, their resources are limited. And I think that particularly when it comes to patient groups and representative groups, and particularly given their charitable status, we obviously will work with all of the groups in a way. I think the structure is challenging because, of course, there is not really one body anywhere actually in and amongst all of the bodies and organisations that can speak with one voice. So what we need to do is to make sure that we've got mechanisms in place across the Integrated Care Boards whereby we're listening to a variety of views and different parts of our communities.
And Dame Linda Pollard, have you got anything to add on the two questions I asked previously?
Yes. At the end of the day, we should, all of us, it's an easy thing to say, more difficult thing to do, particularly when you get complex organisations, but the patient voice should be basically at the centre of what we're doing. We shouldn't make big stuff out, deliver it. But it's how it's owned within the organisations, and it's not just a kind of nice thing to do or a nice thing to say or a tick box exercise. And so in well-organised organisations, and this comes back to governance, that it's owned by a variety of different voices within a governance structure, and that comes through committee level clearly there are some responsible people around the board, with the medical director, chief nurse particularly, but then we're all listening together. It is about getting out. It's about what I touched on before, and feeling the brunt of an organisation by all of us. We've all got that responsibility. And when I say, well, this is not just people sitting around a board, this is senior managers throughout the organisation. But then, you've got a whole process of how you engage with that. Now, whether that's internal, going through those committees, feeding up to board, patients coming to board, patient stories at board, which should be absolutely every single time, patient stories at committees, and people getting into those committees, and absolutely, the good, bad, and the awful news. We have to hear it through complaints procedures, the National Guardian, the ambassadors that feed the National Guardian in organisations. I would also say that there is a delivery, and this involves us all, between the health and wellbeing boards at place level, because we're all in that together. There's patients in there, there's the third sector, there's the charity sector. I co-chair ours in Leeds across the whole city with the local authority. And it's really important because that way we touch everything, whether it's primary care or whatever part of the system it sits. And just while I have this place level, I do think there's an awful lot we could do in joining up a lot more in the whole structure of the NHS, with every respect to the RCB boards. They oversee what we're all doing, but we have a responsibility at kind of place level to get organised between ourselves and to deliver that patient comment, that patient voice, that whether it's staff as well. I would put staff in that, because staff are really the key points of understanding where's it going wrong. And, without a question of doubt, things will go wrong in this big, complex organisation that we're all involved in. But we need to know, and then we need to learn, and we need to share. And that comes back to the things within the report as well, the messenger really.
Thank you. Okay, brilliant. Right, we've got about 8 minutes left. Rachel, over to you.
Thank you ever so much. And Damien, if I can start with you. Patient complaints often become very systemised very quickly, and I reflect on a constituent who spent 10 years in the complaint system, where the resolve really would have been a quick admission by the trust, reflection and engagement. How do we change the culture to ensure that we rapidly respond to the actioning the complaint as opposed to dealing with the complaint?
Yeah, I totally agree. That's terrible. I started my very first post as an independent advisor on complaints, interestingly enough. And so it's a bit of my passion of mine is this. Yeah, it goes back to culture. We get data that comes through our system, and I know lots of other trusts do, so I think I can speak on their behalf as well. But data's one thing, it's how you deal with it and the granularness by which you're looking at it. I put a huge amount of onus of responsibility on my committee chairs, of which I regularly meet separately to find out, and I observe, by the way, that we've really got to get into the complaint system a lot more. I'm a bit fanatical about it. It sits with the chief nurse, and I've got the longevity data that comes through. And if there is a batch of what I would call outliers that is taking far too long, then your committee, your governance structure should point it out. And there may be very valid reasons behind some of it, by the way. It isn't always just what you see on a piece of paper or on the screen. But it's how you deal with it internally, and that's completely unacceptable as far as I'm concerned. But it comes back to how do we share, all of us, the best practice that is within the whole system, and we're not very good at it. Regardless of whether it's complaints or whether it's anything else, and we all know where the good is, but it's just the plethora of things that is the management, the system throws at us to have to cope with. And this should not be a tick box exercise. This is learning. This is how we all improve what we deliver at the front door to everybody. That includes every one of us on this meeting. But there's definitely room for improvement. It should not be a tick box. And 10 years is absolutely, well, first time I've heard of that one, that was dreadful.
Thank you. Sam Allen, if I can turn to you as a system leader. Obviously, we've heard a lot of evidence today about the importance of culture change. As a system leader, how do you bring about that culture change to ensure that the accountability systems are right in the system, but also that you're driving forward as we heard earlier, that culture of curiosity to ensure that we're looking to bring about that change?
Yeah, thank you. So it's very much a culture of collaboration. And of course, with the Foundation Trust regime, we've pretty much seen probably, good 15 years plus of a highly competitive environment, particularly in healthcare. And whilst competition isn't always a bad thing, I think in the context of improvement and culture, we need a mindset, a leadership mindset, which is far more about collaboration, cooperation, and working in partnership. So from an accountability perspective, and using the operating model, ICBs certainly have a role, working with NHS England as the regulator and across all of the services that we commission. That's not just NHS trusts, it would be primary care services, community and voluntary sector services. And we operate an approach whereby we utilise the data, the insights that we have, and we focus on the key issues. And that's very much from a perspective of leadership, culture. It's also looking obviously at performance data in terms of how particular contracts and organisations are performing. But of course, the developmental side really does need to be done together, because there certainly isn't any one part of our complex health and care landscape that can exist in a way which is delivering outstanding services on their own. They're all codependent on one another. So from a system perspective, we've got convening powers of bringing people together. As I said, we've focused on setting up what we've called our learning and improvement community. We've now got 7,500 members of our learning and improvement community. That includes members of the public as well. One of the things that we're doing isn't just leadership development, it's also communities of practice. We've got themed communities of practice around leadership, for example, safe transfers of care, and housing and care is our latest community practice. So really trying to foster a culture whereby everybody's strengths and experience and wisdom are valid, are recognised, it's non-hierarchical, we're open, we're transparent, we're spotting where things are working well, and fundamentally really trying to shape and encourage a culture of peer review. So teams, different organisations in the system going to visit each other. And I think one of the most enlightening parts of that has been perhaps where I would say the areas of our system that have the greatest opportunity for improvement. Some may describe them, the areas as performance issues. I would always say the greatest opportunities for improvement, where we've matched them up or buddied them up with bits of the system that are working well. Actually, both parties take something out of those encounters. So there's learning in this for everybody. So this is something that requires a deep commitment. It requires resources, prioritization, and it takes time. And if I could just sort of conclude by saying...
I'm going to have to stop you there, just because we're just running out of time, and I'd like to put one last question to Professor Kamila Hawthorne, if I may. Just the role of professional bodies and colleges in bringing about culture change. What do you see that role is, and how can you, in a couple of sentences really, how can you bring about that culture change?
Yes. Our charitable object is to foster and maintain the highest possible standards in British general practice. And in this particular area, we're doing it by putting out a patient safety toolkit It's been out since 2017 on our website, freely available to our 55,000 members. It contains things such as prescribing safety, patient safety questionnaires, safety checklists for general practices, significant event audits. And in terms of leadership, we also have an RCGP leadership capabilities framework, again, which is very avidly taken up by members, together with a mentorship scheme to enable people to grow and develop the right cultures, because, as you say, culture is right at the bottom of all of this.
Brilliant. Kamila, just very briefly from me, because I didn't get to ask you a question because we went straight to James Morris, didn't we? Well, I can't really let you go without asking you about the Prime Minister's speech on benefits, welfare, and the sick note culture speech, as it was described. He said, we're going to test shifting the responsibility for assessment from GPs and giving it to specialist work and health professionals. My understanding is GPs have said for years that they're keen to allow appropriately trained others to help in this regard, but has the speech been seen as we're taking this away from naughty GPs by the profession?
It was the words that were used. We're going to strip GPs of the ability to write fit notes. I think it's the way in which it was said. I've had a conversation with Helen Watley since, which has been much more emollient, and which is helping us to see, we're still not sure of the details, ways in which a fit note that we're given to a patient where we think the patient would benefit from seeing a work well consultant, we could then refer on to somebody who's got more time and who's got the expertise in occupational health and so on, to be able to help them back into work.
Were you involved in the conversations before that speech was given?
We weren't involved at all.
Because, in talking about capacity, it's always the challenge, right? And you talked about it with some of my colleagues today, is that anything that helps you with capacity and workload and being able to focus on the key patients is surely a good thing. But I'm just wondering...
We're happy with that.
Who is this other workforce that's going to be these health professionals?
Well, we're not quite sure yet who they're going to be and how they'll be trained and how they'll be employed and who will employ them. And whether, because at the end of the day, our concern is the patient. We want what's best for the patient.
Yeah, and just to clarify, you did refer to the NHS England Fellowship Scheme, didn't you? Which you said that they're getting rid of, were your words.
This is the New to Practice Fellowship Scheme. Yes. It's been running for 2 years, and we heard in January that it was terminating at the end of March.
Okay.
So it's finishing. The monies apparently have been devolved to ICBs, but it's not ring-fenced money, so we fear that it's going down a deep black hole and we won't see it again.
Same old. Okay, so you would, when we make recommendations, you would be interested, just to be clear.
We'd love to work with you on that and give you more detail.
See if we
yes,
can
please. And we have good evidence that they're very successful in keeping people in position and stopping them from going to Canada and Australia.
And that's what this inquiry is about. It's good leadership at all levels, from primary care networks right the way up until Amanda Pritchard herself running NHS England. Very good, excellent. Right, thank you, Sam. We may not have been able to see you, but we can hear you, and you could be in Hawaii for all we know. But never the matter. I suspect you're in North Cumbria, but never the mind. What you said was excellent. We heard you. Same with you, Dame Linda. Thank you very much. And Professor Hawthorne in the room, checking out, signing off. Order.
Thank you.
Thank you.
The proceeding has ended. The proceeding has ended.